Hello everyone, this is Yong-Seok Cho. Welcome to Dentist Webinar. Today I will present with the topic Insight, Concept and Technique for Maxillary Anterior Implant Therapy. Previously I mentioned about mandibular implant therapy. Today I will speak about maxillary anterior implant therapy. My topic is Insight, Concept and Technique. Insight is the ability to see the whole picture and penetrate the essence of a matter. Great insight leads us to the right goals. Concept is the compass that provides directions. A good concept provides the best path to achieve a goal. Technique is the tool that turns goal into reality. The best technique solves problem simply and precisely. Optimal clinical outcomes can be achieved by applying exceptional insight, sound concept, and masterful technique. Okay? This principle will be applied not only anterior maxilla but also everywhere during the implant treatment. What is the goal of implant treatment in the maxillary anterior region? The majority of lectures on anterior maxillary implant therapy focus primarily on achieving aesthetic outcomes. Okay, I can see a very nice, gorgeous lecture which handles anterior aesthetics. But my goal is slightly different. Aesthetics, what is aesthetic? The standards of aesthetic are highly subjective. Since everyone has different expectations, it is very difficult to satisfy each individual's aesthetic preference. Basically, you must make functional rehabilitation in anterior maxillary implant therapy, and also you pursue aesthetic perfection. However, the primary goal should be patient satisfaction. Okay? What is the formula which express the patient satisfaction? It is expressed as a clinical outcome divided by the patient expectation and the overall cost of treatment. Here, costs include not only money, but also the pain the patient experiences and the time required for treatment. Achieving a good clinical outcome is important, but reducing the overall treatment burden is also a key factor to improving patient satisfaction. Most patients are satisfied with a reasonably good result, even if they are not perfect. Okay? In the point of the dentist, you can see some problem in outcome, but patients generally satisfied about such a outcome. Although outcome in these cases may seem somewhat compromised, patient can still be satisfied when they understood that their initial conditions were particularly challenging. Okay? Here is my patient who finished the restoration in this condition. It is the same situation, although it is not perfect, a little bit compromised. However, patient satisfied about the result because his initial condition was really bad. So my goal is satisfy patient. Even if it is not perfect, when patient satisfied, Okay, I achieved my goal. Dr. Jonghyun Park and I developed this classification system which categorizes treatment outcomes into four distinct groups. Okay. Level 1 is excellent outcome, which shown minimal change in labial tissue volume, and sometimes there is minor volume reduction or mucosal recession under 0.5 millimeter. This belongs to level 1, excellent outcome. Level 2, it is acceptable outcome, which shown slightly reduced in labial tissue volume, 0.5 to 1 millimeter. Okay. Level 3 means compromised condition. There are significant reduction in labial tissue volume, 1 to 1.5 millimeter, and also mucosal recession, same amount. Level 4 is a failure. Gingival recession with implant exposed. Okay, when patient volume reduction or mucosal recession is over 1.5 millimeter, it belongs to level 4. To satisfy patient with high aesthetic expectations, level 1 or level 2 treatment outcome is generally required. Okay. However, patient with low aesthetic expectations may be satisfied even with a level 3 treatment outcome. Except for level 4, such a patient will satisfy about the outcome. So depending on patient expectation, we can make different goals. Anterior maxillary region is always challenging because of bundle bone existing at the labial side. Bundle bone is a tooth-dependent structure which holds a periodontal ligament. When we lost the tooth, periodontal ligament will lost. As a result, bundle bone will eventually resolve. Okay? Because of very thin labial bone thickness in anterior maxilla, it is totally bundle bone from crest to about 5 millimeter. So when we extract the anterior tooth, inevitably labial bundle bone will lost. As a result, the volume will be reduced. Okay. And we must consider about the gingival phenotype. We simply classify thin scallop type or thick flat type. Okay. The most important thing in gingival phenotype is response on trauma. Okay. Extraction is a trauma, and our surgery is also trauma to patient. In thin scallop type patient, gingival recession will occur as a response of trauma. On the contrary, thick flat type phenotype, gingival phenotype, hypoplastic reaction will occur. As a result, it is easy to maintain total tissue volume in thick flat type. So, first, I want to emphasize again the goal of implant therapy in the maxillary anterior region. The primary goal of maxillary anterior implant therapy is not perfect aesthetics, but patient satisfaction. Then let me talk about treatment plan for implant therapy in the maxillary anterior region. I will briefly summarize the basic principle of treatment plan in anterior maxilla. Careful case evaluation is critical because there are many parameters which affect the outcome. So you must evaluate bone condition, soft tissue condition, and the patient expectation, etc. Use the minimum numbers of implant necessary while meeting biomechanical requirements. Okay. At molar site, we recommend sufficient numbers of implants to resist occlusal load. However, in anterior maxillary area, you must think about aesthetic outcome also. So to make aesthetic outcome, it's better to place less implant if necessary. Avoid placing adjacent implant whenever possible, because when you place implant continuously, inter-implant papilla height will be lower than normal natural tooth papilla. As a result, it will affect the aesthetic outcome. So better to place less implant and do not place implant continuously. Aim for symmetry of the periodontal and the peri-implant tissue. Okay. Patient can easily notice the problem when it is asymmetrical outcome. Okay. So when we make symmetrical result, the patient don't notice some minor problem, such as gingival recession. But when it's asymmetrical situation, easily notice the problem. When and how should the implant be placed? It depends on condition of extraction socket primarily, whether it is sound socket or pathological condition. So depending on many factors, we decide immediate, early, delayed, or late implant. When patient come because of anterior maxillary tooth problem, it is fracture or caries, but more commonly, it is periodontal disease. It's very rare to see thick labial bone without recession. More frequently, we can see thin labial plate, and in many implant patients, they come to our clinic because of mobility of tooth. It is come from periodontal disease, and they lost labial bone already, although soft tissue looks normal. Here is very frequently quoted, frequently used classification of maxillary anterior tooth extraction socket. Nicholas Elian classified this 2007, and according to his classification, type 1 socket is sound extraction socket. Type 2 extraction socket is resorption of labial bone, but soft tissue height is intact. Type 3 extraction socket means both hard and soft tissue recession occurred already. It's very simple and useful classification. Here, depending on extraction socket type, there are seven kinds of treatment options. Number 1, immediate implant placement without bone grafting. Number 2, immediate implant placement with the intra-socket bone grafting. Number 3, immediate implant placement with a socket shield technique. 4, immediate implant placement with GBR. 5, early or delayed implant placement with GBR. Number 6, socket preservation followed by delayed implant placement. Last, immediate implant placement with hard and soft tissue augmentation. So, depending on clinician's concept, you can select a different kind of options. Okay. Interestingly, type 1 extraction socket, every option can be selected depending on clinician's preference. Type 2, several options can be selected. And type 3 is less option exist. But most important thing is not bone defect type itself actually. Placing the implant in the correct three-dimensional position and angulation is the single most important prerequisite for successful implant therapy in the anterior maxilla. We must carefully control apicocoronal position. That means the implant depth, and the labiopalatal position and angulation, and mesiodistal position and angulation. Look at the apicocoronal position of implant. It means how deep implant should be placed. 화면 이상해. The reference line is mid-facial gingival margin. Okay, from this reference line, how deep implant should be placed. Okay, it depends on implant system, basically. External bone level implant system and the internal gingival level implant system. In the previous implant system, recommended 2 to 3 millimeter deep from the mid-facial gingival margin. However, our current implant system is internal rigid connection bone level implant system. In this system, it's better to place implant a little bit deeper than previous implant system. So, I recommend you place this implant 4 to 7 millimeter from the free gingival margin. This is 4 millimeter deep. I corrected 5 millimeter healing abutment, and it is 5 millimeter deep, 6 millimeter deep, and 7 millimeter deep position. In the past, I recommended about 4 millimeter deep from the mid-facial gingival margin. Now I changed my mind. Generally, I prefer 5 or 6 millimeter deep. Sometimes even 7 millimeter deep from the facial gingival margin. Deep is better than shallow. Okay. When we didn't place the implant ideally, because of some reason, still when we place the implant deep enough, we can compensate some mistake in surgery by abutment emergent profile. So 4 millimeter deep is not bad when it is ideally placed. However, 5, 6 is more preferable because of more tolerance in problem solving. Then let's talk about the labiopalatal position. It is also very critical for aesthetic outcome. We must position the implant to the palatal side. Okay. When we finish the implant installation, the implant body should be contact to palatal bone. Okay. When we place implant like that, spontaneously we can see about 2 millimeter gap between implant and labial bone, and from implant to bone envelope is about 3 millimeter. Okay. This is a usual position of implant. labiopalatal position of implant. 질문이 안 뜬다니까. Okay. This article mentioned about the importance of a buccopalatal position. Okay. They introduced IBP, implant to buccal plate distance, and according to this article, the gap. IBP. When IBP is more than 4 millimeter or 4 mil or less situation, when we made over 4 millimeter IBP, the result was better. So in this article, when they recommended it is better to do GBR when IBP is under 4 millimeter. Okay, they said it's better to do GBR when IBP is not sufficient. However, it looks too much. I think making IBP more than 4 millimeter is not easy. You must place implant too palatally, so it is not practical in reality. in my experience, when I placed the implant the three-dimensionally ideal position, the IBP at central incise was about 3 millimeter. And when it is lateral incise, IBP was about 2.0 to 2.5 millimeter. And in canine site, the canine site, I can make IBP over 4 millimeter, but not in central lateral incise. So, although this article mentioned about the importance of IBP, the dimension looks too much. Okay. This is a type 1 extraction socket which has a sound labial plate. IBP is from buccal labial plate 2 implant. Okay. At central incise, it was about 3 millimeters usual. However, when it is not type 1 extraction socket, when labial plate is lost, we cannot measure IBP. So instead of IBP, I decide to use another terminology named IBE. IBE. E means bone envelope. Even labial plate is lost, we can draw the bone envelope which connect adjacent bone level. Then this terminology can be used, IBE. When we didn't made sufficient IBE, it arises severe, very serious complication like this. Gingivilization will occur, so it violates aesthetic outcome. We can solve the problem with a restorative procedure. However, it has some limitation. So best way to solve such a problem is removing implant. Okay, when it is too labially positioned, better to remove implant and start from beginning. To make sufficient IBE, when you place implant, you must control drill direction very carefully. Do not start the implant position at the root apex. Instead, it should be started at palatal slope and maintain the angulation toward the inside ridge or cingulum, ideally cingulum, and enlarge the osteotomy site to final drill. Then place implant like right picture. Whenever possible, direct the implant axis so that the screw access channel emerges at the cingulum. If this is difficult, labial version within 25 degrees, the cingulum directed screw access axis is acceptable. Okay, ideally try to place implant like A picture. When it is difficult, follow the axis like B. In these days, many companies introduced angulated screw channel solutions that allows the direction of a screw access hole to be adjusted using an angled torque drive. Okay? Therefore, it is no longer necessary to make excessive effort to direct the implant precisely toward the cingulum, as was traditional recommendation. Okay? Even when the implant is placed with a slight labial angulation, the screw channel can be corrected to allow fabrication of a screw-retained restoration. Okay? There are several angled drive available by implant companies. And another addition, several cementless prosthetic systems that have recently gained the popularity can compensate the implant angulation by up to approximately 25 degrees, okay, which allow the fabrication of a screw retained restoration even when implant is placed somewhat outside the ideal trajectory. Okay, so In traditional restoration way, we cannot make screw access hole to cingulum in the left picture. However, in same patient, using a angulated driver, we can tilt the screw channel axis toward the cingulum. Okay. In this picture, the A picture figure shown screw access channel emerges at the cingulum. If ideally we can place like this, this is better because with the usual prosthetic option such as ready-made abutment or custom abutment, we can make screw-retained restoration. So I pursue A-type access hole, the direction. But not always it is possible. At this situation, I aim the implant axis toward the single, the incisor edge, like B, and during the prosthetic procedure, we can tilt the access hole toward the cingulum. However, when the labial version over 25 degrees of the cingulum directed screw access axis is unacceptable. We must do cement retained restoration when it exceeds 25 degrees from the access hole. Cemental restoration is not convenient because there are several problems when it is retained with the cement. With a temporary cement, there's a chance of dislodgement of a crown accidentally. And when we cement the crown with a permanent cement, difficult to retrieve the crown when it is necessary. So it is not recommended. You must control axis at least to the inside edge or slight labially. This article published 2018, and it's good, very good article which mention about the natural tooth root axis and position. Okay. The purpose of this observation clinical study was to introduce a new classification system for anterior maxillary tooth position with a guideline for immediate implant. According to this article, there are several types of TPI, tooth root position and inclination. Class 1 is the root axis and the alveolar process axis is the same, but class 2 tooth is reclined. And A means thick labial bone, B means thin labial bone. Okay. Class 3 is protruded condition. Class 4, 5 is very unique condition. Okay. This article comes from South Africa, and in their population, most dominant class was class 2 tooth reclined condition. And it was the same in Korean population. This is a 31 years old young female patient who planned the anterior implant. When we do maxillary anterior implant therapy, you must consider diverse clinical situations, and there are numerous clinical considerations exist. So it is also highly technically sensitive. So in the maxillary anterior region, the relationship between tooth and alveolar bone varies considerably. These anatomical variations must be carefully evaluated and incorporated into the surgical plan to ensure accurate implant placement. Cone-beam CT is strongly recommended for precise diagnosis and surgical planning. Here is cone-beam CT section of this patient. Which class this patient belongs? Okay, according to previous article, it is class 4 condition. Okay, class 4A maybe. Okay, what is the meaning of the TPI? The radial tooth root position and inclination affect whether it is possible or easy to make screw retained or cement retained time. Okay. Ideally, better to make angulation toward the cingulum, but not always it is easy or possible, depending on classification. In class 1 and class 3 cases, it is relatively easy to direct the implant angulation toward the cingulum. In the other classes, however, achieving this ideal angulation is more difficult. When we try to make angulation toward the cingulum in class 2 or class 4, 5, you will experience labial plate perforation. Again, let me show you details about control of implant axis. When TPI class 1 and the TPI class 2, let's compare. Class 1, this is alveolar bone axis. Alveolar bone axis. In class 1, this is tooth axis, and right is class 2 tooth axis. In class 2 case, the tooth axis is retroclined. That means it is very difficult to make screw retained implant surgery because of anatomic variations. Here, class 1 TPI case. In such a situation, depending on the starting point, sometimes it is easy to make screw retained axis easily, sometimes it's difficult. Basically, in such a class 1 TPI, better to start the palatal slope, which is apical third. Okay, we divide the palatal slope, apical, coronal third, middle and coronal third, and better to entry point position at the apical third. Apical third. Look at the diagram A and B. When we position the entry at apical third, depending on amount of palatal bone reduction, the axis will be determined. When we reduct the palatal bone to less, the axis will be toward the inside ridge. However, when we try the effort to reduct the palatal bone slightly more, it is moderate reduction, the axis will be toward the cingulum. It is not so difficult. So I recommend you follow that axis. Okay? Technically, it is not so difficult, and finally, it will be screw retained restoration. So this is clinical priority number 1, B diagram. When we reduct the palatal bone much like diagram C, it is toward the cingulum. Okay, it is also possible, but I don't recommend do not grind the palatal bone too much. It will arise another problem, which means during the restoration, the palatal bulging will occur, which make patient discomfort during the touching. So this is not recommended. Sometimes to make axis toward the cingulum, I aimed the entry point more apically. Okay, it is 1/4. Okay, it is possible. However, in such a situation, you must care not to perforate the labial plate. So my clinical priority is B number 1 and D number 2. Anyway, it is not so difficult to make screw retained restoration in class 1 TPI. When we position the entry point to move to more coronally, such as middle half of the palatal slope, it is not easy to maintain accessor toward the cingulum unless you reduct the palatal bone very much. Okay, so when we start entry point 2, more palatal, you must reduct the palatal bone highly. That's not my recommendation. So key point is that in class 1 TPI, starting entry point should be apical third. Let me think about the class 2 TPI. Here, class 2A and B situation. In such a situation, when we start entry point apical third, it is not easy to avoid apical fenestration. Okay, it will perforate apically when it is positioned to apical side. So I recommend you start entry point at middle half of palatal slope in case of class 2 TPI. Okay, look at number C. The entry point is middle half, and palatal bone will be reducted moderately. Although the axis is toward the inside edge, it is not bad. It is not bad. We can convert accessor with the angled drive. So this is my number 1 priority in class 2 TPI. It is not easy to make screw retained axis starting with the class 2 TPI. If you want to do that, you must reduct the palatal bone very much. Okay, then the accessor will be toward the cingulum. This is the second choice, alternative choice. So do not try to aim scroll at cingulum in class 2 TPI. In summary, class 1 TPI entry point is apical third, and in class 2 TPI, better to start entry point at middle half and do not try screw retained axis. Better to aim the inside edge. That's more favorable and easy way. Okay, here is the mediodistal position and angulation. Okay, look at the natural tooth root axis in anterior maxilla. It is slightly medially tilted. The root is toward the distal, toward the slight distal, not too much. Okay, so we follow the axis of implant. We mimic axis of implant with the natural tooth root. So it is slightly medially tilted. And think about the entry point in this picture. Generally, when it is type class 1 TPI, it should be apical third, so entry point should be there. Okay, apical third, and it is slightly distally positioned because root is distally tilted. Okay, here is my cases. When I place the central incise implant, starting point is slight distal and the tilt slight medial. Okay, this is my usual path control. Although this is not critical, even you place implant straight, many cases it is acceptable. However, some patient has a very big nasopalatine canal. Okay, to avoid encroaching to nasopalatine canal, you must tilt the implant slight medially. Okay. Look at this dry skull, which displays the very thin labial plate. 한번 두드려봐, 그거를 창문을. Okay. This is the root apex. This is the root apex. And when we start the entry point, it is here. When it is class 1 TPI, apical third. When it is class 2 TPI, it is middle half. Okay. So carefully evaluate the case, and at starting, you must point the entry point depending on TPI. Here is a dentist drill system. So the entry point is apical third with Lindemann drill, and then enlarge the hole with keeping pass to last drill F4.0 set drill. Sometimes I do overcorrecting the direction toward the palatal side slightly and place implant. Okay, look at this model surgery here. When I do model surgery, I carefully examined the palatal slope, root positioned labially, and the entry point is apical third here. Touch the apex and then move along the palatal slope, and aim the apical third. Here, apical third. Then start. And try to keep slight medial tilting, which mimic natural tooth. In immediate implant case, mostly I like to place the diameter 4.0 and the length 11.5 millimeter. And it's slightly toward the cingulum, if possible.
13mm를 해보도록 하겠습니다. 이번에는 3.5, F3.5에
Test enlarge the hole, with keeping the same pass.
자, 마지막
At last,
4.0에 13이 되겠습니다.
4.0 drill will be used.
자, 이렇게 드릴링이 끝난 모습이 보입니다. 자, 4에 13mm를 심도록 그렇게 하겠습니다. 자, 드릴된 상태를 보게 되면은 팔라탈 쪽으로
It is well prepped hole toward the palatal slope, and then place implant as we planned.
한번 볼까요? 사실 지금 정면에서 봤을 때는 괜찮습니다. 뒷면에서 봤을 때도 레비얼 쪽에 공간도 보이고 각도도 조금만 더 팔라탈 한번 가도록 해보겠습니다.
Okay, like this. Here is a female patient who has low aesthetic demand, and bone and soft tissue slightly reduced, but patient wants simple implant surgery. Here, I aim the apical third at starting and keep the pass slight mesial and slight palatal. One more point is that please use drill extension always when you prep the osteotomy in anterior maxilla to avoid interference to adjacent teeth and maintain the pass well. Better to use extension always. At the finish, place implant. Okay. Although the surgical time is very short, you must keep in mind the basic principle in anterior maxillary implant case. control depth and finish. And generally, it's better to perform intra-socket bone grafting. Here are again the classification of extraction socket, and many options exist. Okay. Treatment option vary according to defect type, but the choice often differs among clinicians because of difference in treatment concepts. Me prefer second treatment option. It is immediate implant placement with intra-socket bone grafting. It is highly efficient and reliable treatment approach, and it is therefore most commonly selected option. It is simple, comfortable to place implant, and reliable outcome. So in type 1, maybe many dentists prefer number 2 treatment option. When we place the implant exactly, there exists about 2 millimeter gap between implant and labial plate. When we don't graft that, don't fill the graft material at the gap, we experience more volume reduction. So to minimize the volume reduction, we prefer intra-socket bone grafting. Although this is not perfect solution to preserve labial volume because we cannot prevent resorption of a bundle bone. However, with the intra-socket bone grafting, we can reduce the amount of resorption about 0.5 to 1 millimeter compared to no bone grafting. The final outcome depends on the gingival biotype and the type of graft material. Let me show the clinical case here. This is right lateral incise case. Patient came because of a fracture of lateral incise. Here, it is a type 1 extraction socket, and the TPI was class 1A TPI. So this is not so difficult case. We can easily make access toward the cingulum, but lateral incise is relatively thin bone with us. Here I extracted the lateral incise with a nice root elevator, and then prepped osteotomy as I mentioned before. And at that time I used Dentist SQ implant, diameter 4 mm and 12 mm. After placing implant deep enough, I checked the position of implant. It is palatally positioned, and ISQ value was 12 Newton centimeter, ISQ 74, 72. Here, intra-socket bone grafting was done like this. I connected the 455 healing abutment and finished the surgery. Okay, look at the video of this case. Okay, atraumatic extraction is the first step when we do implant. Okay, use a fine luxate elevator. That is the best. Okay. After extraction, I started the entry point apical third with a long drill and maintain the path toward the cingulum. Check the apical hole, drilling hole, whether it is passed or not. Okay, after final drill, SQ implant was placed. At first drill, depth was not sufficient, so it spinned. So prep the hole again. Okay, ISQ value was not bad, but generally we recommend the intrasocket bone graft. I grafted the xenograft very lightly filled gap. I omit flap approximation and finish the surgery. Here, POP, panoramic image, implant placed deep up and slightly tilted toward the distally. It is same I mimicked the axis of natural tooth root. Okay, like this. In CT view, it is well positioned. In type 1 X-section socket, when you start entry point, apical third, it will be finished like this. Okay, no labial perforation. I didn't grind the palatal bone too much, but still maintained IBE adequately. This is summary of this surgery. It is missing of maxillolateral incisors in young male patient, and his aesthetic demand is not so high. And the socket type was type 1 X-section socket, TPI class 1A, phenotype, gingival phenotype, thin phenotype. And finally, IBE was approximately 2 millimeter. Implant was SQ. That's not 4.0, 3.5. Intrasocket bone grafting was done. And the expected aesthetic outcome is level 1 or level 2. 1 week later, healing was uneventful. PLIF was made and delivered. 4 weeks later, ISQ exceeded 78, and cement wrist restoration was planned. Connect the base abutment and scan the case, and with the digital process, definite restoration fabricated. This is the final outcome of this patient. Okay, the lateral incisor crown was cement wrist crown. In the periapical view, okay, a very nice condition in the radiograph images. So this is summary. When intrasocket bone grafting was done in type 1 X-section socket, final outcome was level 1, excellent. So here you can see the picture. There's minimal change in mucosalization and volume reduction. So the case finished very well. Okay, next case is also lateral incisor case who complained of the mobility of left lateral incisor. The patient was in diabetes. Okay. In radiographic image, we can see minimum bone resorption, alveolar bone resorption. However, clinically, the mobility was very severe, severe than radiographic image. Okay. Number 22 was type 1 X-section socket, and TPI was class 2B condition. There was a deep pocket on the labial side. Although in radiograph image it didn't displayed well, but the labial deep pocket exists, and it was simply extracted. Then osteotomy as a normal bone. So last drill was F4.0 set drill. Before implant installation, I measured the depth of a hole, osteotomy hole. It was approximately 14.5 millimeter. Then here I selected the implant 4.2 by 9.5 millimeter XL implant. I can get very strong primary stability, 50 Newton centimeter, and ISQ value was 82, 83. Okay, the implant positioned palatally, and the gap between implant looks about 2 millimeter. Intrasocket bone grafting was done as a routine way, and connected the healing abutment. The height is 5 millimeter. Gingival height is 5 millimeter. That means from the facial gingival margin, it is 4 millimeter deep. It is not so deeply placed. Here, look at the video of this case. It was a mobile condition, and I extracted tooth very simply. The labial plate was intact. Well, look at, you can see the pocket. And here I aimed the entry point at palatal slope, apical third. This is a 3.5 set real, and check the condition with the depth gauge. Okay, keeping medial angulation slightly, finished osteotomy. Okay, well prepped osteotomy at palatal side. XL implant was selected and placed. In such a situation, we must anchor the implant at the palatal slope and the apical portion. Such a aggressive pin in the XL implant is very helpful to get primary stability. Intrasocket bone grafting was done. Surgery finished. Generally, not always it is necessary to approximate the flap. Many cases I don't approximate, just to finish. POP panoramic image showing nice axis of implant slightly medially inclined. That's my preference. Okay, CT view here, not bad. It is toward the cingulum. So in summary, 67 years old male patient who has low aesthetic demand placed implant with a Dentist XL implant. And I grafted the bone slightly, and expected aesthetic outcome is level 1 or level 2. Okay, let's compare before and immediate post-op. Here, 5 weeks later, ISQ value was not sufficient, only 65. So wait again until 2 months and 2 weeks. Okay, ISQ value reached to 73, 72, and restoration made and delivered to patient. Okay, this is final outcome. In the radiographic image, it's well positioned, and in CT view, okay, not bad. Again, in this case, it was the type 1 socket, and the TPI was class 1B, and favorably, the gingival phenotype was a thick phenotype. As a result, final outcome ended up level 1. Excellent outcome. Okay. So in type 1 extraction socket, usually I do intrasocket bone grafting with immediate implant, and when we position implants three-dimensional well, the result is always satisfactory. Okay, we can get at least level 2 outcome. Mostly in thick, nice gingival phenotype patient, generally it will ended up as a level 1 excellent outcome. Then let's move to the type 2 extraction socket, which lost labial bone. In such a level type 2 extraction socket, there are several available options. One is immediate implant placement with intra-socket bone grafting, or GBR, early implant with GBR, socket preservation followed by delayed implant, or immediate implant with hard and soft tissue augmentation. Generally, when we open flap, the surgery will convert it to complex one. So you have to do GBR in type 2 extraction socket. Okay, maybe the outcome is not bad. Okay, however, surgery will be relatively complex. Will become complex. If I can make same outcome, I prefer simpler way. So in type 2 extraction socket, my choice is generally second, immediate implant placement with the intra-socket bone grafting. Maybe this is the same as the type 1 extraction socket. Here is a patient who has severe mobility on central incise, left maxillary central incise. It was severe mobility with fistula and type 2. Gingival height is not bad, so it is type 2 extraction socket. I extracted the tooth 1 week after the extraction. Although this is also immediate case, tooth is already lost, and look at the CT view. Not only labial bone, but also palatal bone was lost. So in such a situation, vertical augmentation is very challenging. When it is just the resorption of labial side, I don't try complex surgery. But in such a both labial and palatal bone missing, sometimes I do GBR. So in this case, I open the flap widely to expose the defect and the debridement of the pathological tissue in the socket. And look at the left lower picture, there are vertical bone resorption. Implant was placed, and then GBR was done. Implant didn't submerge. It is non-submerged implant with GBR. Open the flap. Better to open flap widely. Okay, it is a remote vertical incision from the defect. And the granulation tissue was removed. Three-dimensionally implant should be well positioned regardless of extraction socket. So I prep the osteotomy carefully, keep in mind the principle of three-dimensional implant position. After the last drill, here I placed the implant. The stability of implant was not bad, so I can do non-submerged implant surgery, which has advantages during the GBR. When you don't submerge the implant, no need to pull the bacal labial flap too much. Okay, here I duplicated the template to the membrane. Okay, using healing abutment, I fixed membrane. Graft bone graft approximate flap. In type 2 extraction socket, when you open flap, it is a GBR case. If you don't open flap, sometimes you can omit GBR. Okay, the last I approximated flap and finished the surgery. Okay. Implant didn't submerged, connecting healing abutment. Okay, this is POP radiography images. As I planned, the implant well planned toward the paracingulum and the much bone grafting on labial side. Okay. Patient has thick phenotype. That means the prognosis is not bad. Okay. I expected the level 1 or level 2 outcome. Here, provisional restoration with a flipper. 2 weeks later, connecting base abutment for cementless restoration. Took impressions, scanning was done, and the provisional restoration delivered to patient. Okay. 3 weeks later, final impression was done with a digital way, and this is definite restoration with a monolithic zirconia, and the final outcome is here. Okay. In CT view, the grafted bone well maintained, and clinically minimum gingival volume reduction and recession was observed. Okay. 2 years later, no big change. POP 3 years and 2 months. Okay. Let's summarize the case. It is a middle-aged female patient who has moderate athletic demand, and the socket type was type 2, thick phenotype, IBE was made about 3 millimeter, and bone graft GBR was done. Final outcome was level 1, excellent outcome. Another case of type 2 extraction socket. Here, patient complained the mobility and the discomfort of left central incisor. Here, it is in post crown condition and mobile with fistula. This is a type 2 extraction socket and the class 1B TPI. Okay. There was a soft tissue perforation during the extraction. Okay. The gingival was very thin at the site. In such a situation, just to do GBR is not favorable. Better to try connective tissue graft. Labial bone plate was lost and relatively thin. I planned the connective tissue graft combined with the intrasocket bone grafting. At the placing implant, the pocket was made with a sharp blade and harvested palatal connective tissue. Okay. The connective tissue was positioned labially. Okay. It is combined with the intrasocket bone grafting like this. In the POP, panoramic image and CT, peripheral view, well-positioned implant. Patient has a relatively thin gingival phenotype. CT graft can convert the biotype to thick phenotype. Okay, this is advantage of do connective tissue graft in maxillary anterior region. And expected outcome is level 1 or level 2. Here, provisional restoration was delivered and maintained for 7 weeks. 3 months and 3 weeks after the delivering immediate provisional restoration, well-healed condition, so crown was made. Okay. This is a single crown delivered to patient. So this is a comparison of before the operation and after the restoration. Although clinically there's no big change, in reality the left lateral incisor has very severe bone loss actually. And 3 years and 10 months after the delivering final restoration, CT was took again. Okay. Because of volume of soft tissue, connective tissue graft, on the labial implant side, the newly formed bone looks relatively thin. Although it is not absent, it is present because of the soft tissue. Connective tissue was pushed the graft material toward the implant site. That's why it happened. Clinically, it is not bad. It is in healthy condition, and athletic outcome, athletic score was also level 1. Okay, excellent score. When we try GBR or connective tissue graft in the level 2 extraction socket, generally we expect level 1 outcome. However, the surgical technique will be more complex and hard to patient. Harvesting connective tissue is challenging to patient. So this previous case was a special situation. So I tried the GBR or connective tissue graft in special situation. Generally, I don't like that option. Even if possible, I will omit complex surgery, like this patient. Here is a patient, 40 years old male, and complained of the mobility of 21 and 31. Okay, in radiograph image, root was very short, and the labial bone was partially reserved. This is a typical type 2 extraction socket. After extracting 21, breast osteotomy until the 4 by 40 millimeter set drill, and the placed implant. Placed implant 4.2 by 9.5 millimeter. I can get strong primary stability, so I decided to connect healing abutment. Before connecting healing abutment, intrasocket bone grafting was done as a routine way, and surgery finished. This is a summary of this case. In 40 years old male patient who has low aesthetic demand, the type of socket was type 2, class 1B extraction socket, and gingival phenotype was very thick. Okay. Placed implant and expected the level 2 outcome. Cementless restoration was done by my prosthodontic partner, and here is the final outcome of this patient. Okay. Screw hole access to lingual side slightly. 5 months and 3 weeks later, here POP 9 months. POP 9 months, implant well positioned. Okay. So this is lateral, the left central incise case, which is type 2 extraction socket. But in such a type 2 extraction socket, I just tried the implant with the intrasocket bone grafting, and look at the final outcome. Not bad. It is acceptable level. with a minimum effort. Okay, this patient really satisfied about the outcome. This patient also maxillary anterior case. Okay, there are several questions from Korean dentists, so I will give you question and answer. The question was compared to delayed implant. During the immediate implant surgery, do I expect more vertical gingival recession in maxillary anterior? So if you expect too more gingival recession, is it better to place implant deeper? In ITI group consensus, they recommend do not try immediate implant because of high instance of mucosal recession after restoration. Okay, the instance is very high, about 0.5 to 1 millimeter mucosal recession occur in immediate case. Maybe compared to healed site, 0.5 to 1 millimeter gingival recession may occur, but it is not so critical in many patients. It depends on gingival phenotype, basically. In my routine way, such as immediate implant with intrasulcopharyngeal grafting, many of my cases belong to class 1 or level 1 or level 2. That means mucosal recession is under 1 millimeter, and most of patients will accept that condition. So even in this immediate case, my routine implant placement is slightly deeper than healed site. It is 5 millimeter. This 5 millimeter. In healed site, I can place implant 4 millimeter. Okay, minor difference exists. A little bit deeper implant installation is better than shallow one. So 5 millimeter looks not bad. Okay, in healed site 4 is okay. However, in immediate implant case, I recommend you to place 5 millimeter deep from the midfacial gingival margin. Another question from same dentist. In such a canine site which is difficult to extract, he said, I must open the flap for extraction. At this situation, the reference point, midfacial gingival margin, will be lost. Then, how can control depth of implant? Okay. Basically, the basic principle of depth control is first from the gingival margin. From the gingival margin, after healing, minimum 4 millimeter. I recommend minimum 3 millimeter, but 4 is better. When we place implant 4 millimeter from the gingival margin, implant should be inside the bone. Okay, the rough surface should be inside the bone. We must match the two factors simultaneously. Okay, from gingival margin, minimum 4 millimeter, and inside the bone. When you open the flap, think about the gingival thickness before reflecting the flap. Generally, it is 3 millimeter. Okay, not always. Generally, on the maxilla, it is about 3 millimeter. That means to place implant 5 millimeter deep from the gingival margin, you have to place implant 2 millimeter subcrustally. Okay, and the final decision is made correcting healing abutment. Okay, I usually select the gingival height 5 millimeter. So approximately control depth of implant about 2 millimeter subcrustally, and then correct healing abutment, then approximate flap, and evaluate again. When your healing is exposed more than 1 millimeter, that means still it is insufficient depth. That situation, disconnect the healing abutment and advanced implant a little bit deeper. Okay. Finally, it should be 4 millimeter deep from the healed gingival margin. Okay. And one more thing is that do not open the flap, even it is canine or endodontic treated tooth. In this stage, CT is available. So we can evaluate the root condition with the CT section. And when we carefully use instrument such as luxate elevator, fine luxate elevator, no need open flap. When you feel trouble during the extraction, I recommend tooth sectioning instead of opening flap, tooth sectioning. Or sometimes I do transradicular drilling. Before extraction, I start the drilling, okay, osteotomy. After osteotomy, extract the root remnant. Okay, so in immediate implant anteromaxillary case, very rare to me to open the flap. Okay, because when I open flap, surgery will be more complex. Another question. When I do open flap and try GBR, what kind of membrane I used? I used the resorbable membrane. There are so many kinds. It is not so critical. In these days, many companies supply nice membrane, resorbable and acceptable membrane. I think anything is fine. It is not so critical. Okay. Okay, any question? Then please write in the board. Okay, let me continue. Well, this female patient has a relatively poor periodontal condition, so it was splinted by previous dentist to reduce the mobility. And in the radiographic image, very poor bone level, we can see. So here, right lateral incisor and the left central incisor was hopeless condition. I decided to extract this. Okay, this is type 2, typical type 2 extraction socket, and the TPI was class 4 TPI. Class 4 TPI, it is difficult to control path of implant. So, in such a situation, do not try to angulate the implant toward the cingulum. So, focus on not to penetrate the apex. And then, finally, the axis will be toward the incisor edge. After extraction, I checked the labial bone. It was gone. Okay. But I didn't open the flap. If we open flap, it will be GBL case. And control osteotomy, same as type 1. Okay, the osteotomy principle same as type 1. Carefully control and place implant. It was type 4 TPI, so the axis was toward the incisor edge. It is difficult to avoid the penetration if you try to tilt lingually. Okay, this is position of implant, which position the palatal side and sufficient gap exists in 21. ISQ value not bad. I combined porcine bone and bovine bone for internal socket bone grafting to test. Okay, yeah, and connected the healing abutment. Then extracted the lateral incisor of right maxilla. Same situation. Labial bone was there was penetration, not dehiscence. Because of less bone thickness and type 4 TPI, I planned mini-sized implant. So final drill was F3.5 by 12 millimeter drill, and XL 3.8 by 10 millimeter implant was placed. 70 Newton centimeter, very strong prime stability I can get. Again, intra-socket bone grafting was done. Connected the healing abutment. Okay, it's mini connection, healing abutment. Okay. In this case, I control the depth almost 5 millimeter at lateral incised and the left central incised 4.5 millimeter deep. Okay, like this. Look at the CT view of this case. I control the axis toward the cingulum and avoided the apical penetration. Okay, this is not bad. Intrasocket bone grafting was done sufficiently on the labial side. Periapical view. And here is summary of this case. Patient has low aesthetic demand. This is good news to me. And TPI was not good. Type 4 patient has a deep gingival phenotype, and sufficient IBE was given. I get, and bone graft was done. I expected a level 2 acceptable outcome in this patient. Pass control was done. It looks too much tilted, so immediately control the pass. And for provisional restoration, took impression connecting cement wrist base abutment. Okay, yeah. Provisional restoration delivered to patient. After nice healed process. Definitive restoration fabricated. Okay. The last crown delivered to patient. Okay. And here is a CT view. Okay, labial bone well maintained. Comparing the preoperative condition and outcome, I can see minor mucosal bone, minor volume reduction occurred on right lateral incised and left central incised. So final outcome was level 2. This is also acceptable to patient. It is a very cost-effective way in reality. Okay, patient was satisfied about the result, and I did a minimal effort to make this outcome. Okay. This patient, this case I already shown on the left for left lateral incised. In same patient, here you can see the fistula, the buccal gumboil on the right central incised. Here, and it's shown. Apical lesion, big apical lesion, which perforated the labial bone. It is type 2 extraction socket, and the TPI was classed 1B TPI. Okay, it looks like this. Okay, because of a root fracture, it happened. Okay, patient displayed root fracture. It was extracted. After extraction, I found loss of labial plate. Okay, this is a typical type 2 extraction socket. So I prepped the osteotomy as a routine way, carefully controlled direction, and the final drill was f4.0 by 40 millimeter, and I didn't prep the osteotomy completely. It partially prepped osteotomy. And after finishing osteotomy, I always measure the total depth of osteotomy site, okay, to select the length of implant. Generally, the diameter implant is chosen depending on the location of implant, but length should be selected depending on the depth of osteotomy hole. Depth was approximately 17 millimeter. if you minus 5 millimeter from here, it is 12 millimeter available bone. Then we can place 11.5 millimeter implant. That's ideal in such a situation. Like this. Here, I chosen XL 4.2 by 11.5 millimeter long. Okay, and it was placed sufficiently deeply. Okay, 5 millimeter deep from the mid-facial gingival margin. Okay, strong primary stability I can get. Okay, this is the advantage of using XL implant. Okay. Intrasocket bone grafting was done. Although labial bone is gone, I can do just intrasocket bone grafting without the flap elevation. After graft, connected the healing abutment. This time, because I placed the implant relatively deep, I chosen 5 diameter and 7 millimeter long healing abutment. Okay. Look at the video of this case. Gum boil, we can see at central incised, it is fractured root. Okay. Use extension very actively when you prep the osteotomy at maxillary anterior site. 3.5 drill and 4.0 partially, and depth was deep, so I selected 11.5 millimeter long XL implant. I can anchor the thread of XL implant at apex with a strong primary stability. Here again, I tried the simple intra-socket bone grafting. Do not press the graft material, just feel the gap. And then let's finish the case. Okay. Here, POP, panoramic image looks well positioned implant visuodistally, and the depth is also not bad. Look at the CT view here. The path was also relatively well controlled without labial perforation. So this is summary. Type 2 extraction socket, class 1A, thick gingival phenotype, and XL implant with intrasocket bone grafting. So expected aesthetic outcome level 1 or level 2. Here, cementless restoration was planned, and the provisional restoration directed on the implant. 2 months after the placing implant, gingiva was well healed and looks very stable. Look at the level of cervical gingival margin. Until now, there's no recession. And the definite restoration fabricated and then delivered to patient. Okay, like this. Here, in this case, although it is level type 2, type 2 extraction socket, I just tried simple implant plus intrasocket bone grafting, but final outcome was level 1, excellent. Okay, if you do GBR, if you do CT graft, same result will you can get. However, which is simple and which is easy in same outcome, better to use a simple, effective way. This is a multiple implant case who missed the central and the lateral incisor and the left lateral incisor. Here, it is already bone healed and resolved condition. In such a situation, it is very difficult to make a natural scallop in anterior maxilla. If you want to do perfect aesthetic, you must do vertical GBR extensively. Then we need multiple surgery, and then finally we can make a nice aesthetic outcome. But is that necessary to patient? That's the question. Many patients already in such a visit with such a condition never want perfect aesthetic. Actually, they want to solve the problem as simple as possible. So, depending on patient demand, my approach is different. In this case, the patient wants a simple implant with a comfortable restoration. So, in clinical view and radiograph image, I evaluated the case carefully and planned the implant surgery on the maxillary anterior region with the 2 implants. Okay. In this case, I placed 1 implant at the left central incisor because bone was relatively good at this site. And here, after extracting 1 more implant, and the canine was also placed. Okay. Here, canine was extracted and placed implant. Here you can see that the big gap between canine implant and the labial bone. To minimize the reducing the canine eminence, intrasocket bone grafting was done. Here, healing abutment was corrected like this. This is a POP panoramic image. I can use existing implant on the right maxillary lateral incisor, and I added 2 more implants. Okay, yeah, 21 and 23 implant I placed. Healing was uneventful. However, we cannot make aesthetic papilla in such a way. If we want to make perfect aesthetic outcome, we need a CT graft one more time, but patients don't want it. So here, after healing with a digital process, final restoration made. Although it is not aesthetically perfect, patients satisfied about the outcome. 1 year after bridge delivery, it is very stable in condition. Here in the radiograph image and CT view. Here, look at the stable labial bone. Volume is stable and looks nice condition. So this is summary of this case. Okay, at last, I want to mention about type 3 extraction socket. It is quite different situation. Not only bone, but also soft tissue is gone. In such a situation, a simple approach is impossible. So generally, we do early or delayed implant with GBR, or sometimes we try socket preservation followed by delayed implant placement. Although immediate implant placement with a hard and soft tissue augmentation is possible, it is a relatively complex surgical procedure and relatively unpredictable. Sometimes I do this when patient want it, and in favorable situation I try, but this is not general recommendation. Instead, we usually recommend option 5 or 6. Okay. So type 3. In type 3 extraction socket, when the patient has very low aesthetic demands and the degree of soft tissue and hard tissue loss is minimal, or when when the adjacent teeth have already experienced both soft and hard tissue loss due to periodontal disease, I do immediate implant placement alone. Sometimes add intrascapular grafting without flap elevation. This may be considered as a simple treatment option, but this option should be applied in limited situation, low aesthetic demand, and already other tooth has experienced periodontal disease. That time, for simplicity of maneuver, I try just place implant with intrascapular grafting. However, in many severe type 3 case, which recess soft tissue too much, we cannot do such an option. At the time, it is better to do delayed or early implant placement. Okay. There are two options in type 3 extraction socket, depending on condition of extraction socket. In same bone and the soft tissue resorption condition, the surrounding soft tissue, which is actually this fiber tissue condition, there are two ways. When it is type 3, which lost the labial plate and the gingivalization, and but the tooth is relatively intact condition. I mean, the palatal or apical portion, there's no pathology. At that situation, there are two different tracks. Anyway, both cases, we simply extract the tooth. Generally, it's mobile, so it's to extract. In the left situation, I recommend you do early or delayed implant placement with the GBR. That means just extract. However, when it is right situation, which is mobile, severe mobility, and encapsulated by fibrous tissue, we can do this option. Socket preservation followed by a delayed implant placement. Okay. During the extraction, we do something and wait. Okay. On the left side here, after extraction, a provisional restoration is relieved with a flipper, or sometimes cut the existing crown and the splint together to adjacent teeth. And about 3 months later, we do implant installation, and if necessary, do bone graft or GBR at that time. Maybe when you wait some months, the socket will be partially healed and soft condition will be much improved. So it is to do place implant and GBR. When we tried socket preservation already, we can follow the right guideline. During the socket preservation, do not remove the fiber tissue on apical which surround the tooth. Instead, the incision must be made at palatal side. Then carefully raise up, detach the fiber tissue and raise up. Then we make a pouch like this. Inside that pouch, we graft some graft material and approximate the flap with loose suturing. Then wait healing several months. About 3 months later, open the flap. When there's sufficient bone regeneration, just try simple implant installation. However, when it is insufficient already yet, then try additional bone graft. So that is a simple way. Okay, let me make conclusion about this topic, anterior maxillary implant. Okay. The most important goal of anterior implant placement is patient satisfaction. Functional rehabilitation, aesthetic perfection is also important. However, the primary goal is patient satisfaction. Aesthetics should always be considered, but do not become overly obsessed with achieving perfections. Okay. In the maxillary anterior region, reducing the number of implants whenever possible within the biomechanical acceptable limit is generally advantageous for aesthetic outcome. Okay, don't place implant continuously. Carefully evaluate the clinical condition and establish an appropriate treatment strategy according to the extraction socket type. Three-dimensionally accurate implant placement with a proper angulation is the most fundamental prerequisite for successful implant treatment in the maxillary anterior region. Assuming that the implant has been placed in an appropriate three-dimensional position, gingival phenotype has a major influence on the treatment outcome. When patients detect biophenotype, generally we can obtain acceptable outcome even with less effort. In type 1 and type 2 extraction socket, intrasocket bone grafting after immediate implant placement is a highly efficient procedure and generally provides favorable outcome. So this is our general recommendation in most type 1 and type 2 extraction socket. In type 2 extraction socket, when you open flap, you have to do GBR, or sometimes to make perfect case, we add a CT graft, which improve the outcome better than other way. Do this when it is indicated, but they also make the procedure more complex. Okay. Final statement. By selecting a reliable and efficient surgical approach based on the patient aesthetic demands, extraction socket type, gingival phenotype, and other clinical factors, implant treatment can achieve outcome that satisfies both the patient and the clinician. Okay, this is my last word. Okay, thank you for your attention. And this is our third session of our webinar. Okay, here is one question here. In anterior site, when I do flapless surgery, I said option 2, flapless surgery, immediate implant without open flap, and just do intrasocket bone grafting. And when I do GBR extensively, it depends on the condition of bone loss. When patient has, there are two options, two considerations when I do open flap or not. First, what is the bone resorption condition, just labial or combined palatal? That means when patient has type 2 extraction socket, but it is a vertical resorption, not only labial, or it is resorption of palatal side, better to open flap. At that time, I do GBR. Okay, just with the intrasocket bone graft, it is slightly unpredictable. So when one side wall defect, I don't open flap. I don't open flap, but both side, both labial, palatal is gone, open flap and do GBR. And one more thing is the gingival phenotype. When patient has a thick gingival phenotype, the outcome is really predictable, even with a minor effort, such as flapless intraocular bone grafting. It is good. However, when patient has a thin gingival phenotype, and sometimes even there's some fistula already exist, there's more chance of gingival recession. At that time, sometimes I do GBR. Sometimes instead of GBR, I do connective tissue graft. Okay, to convert the gingival phenotype to thick phenotype. Okay, it is also predictable outcome. Although harvesting palatal connective tissue and the CT graft is relatively technically sensitive when you master soft tissue handling, it is also a nice option. Okay. Okay. Oh, one more. No. Okay. I think question is finished already. Not so many questions in this session. Okay. I think I will think this is good news to me. Anyway, in the previous session, I mentioned about mandibular case and the maxillary anterior today. And the next is the last my webinar session, and it is maxillary posterior implant therapy. It is also involved in sinus bone augmentation surgery. So I'll prepare well and want to see you 3 weeks later. Okay, thank you very much for your kind attention.